Hello, Overcomers, and welcome to this episode of Connect Over Coffee. I am Runsi, the founder of Overcome, and today we are joined by a very special guest and a special friend, Dr. Rachel Grisham. So, Dr. Grisham is the section head of ovarian cancer at Memorial Sloan Kettering Cancer Center. She is regarded as a global expert in rare ovarian cancers and is involved in many groundbreaking initiatives in this space. As you may imagine, we have several things to learn about from Dr. Grisham today and ask her questions of. So join us for the next 45 minutes to an hour. Have your beverage or coffee ready. I have mine. And let's connect over coffee with Dr. Grisham as we chat with her on all things rare ovarian cancers and also discussing recent hot topics in this field. And if you have any questions as we go along, please type in the comment sections below and we'll try to get it addressed post the discussion. So with that, a huge welcome back to you, Dr. Grisham. We love you. Our overcomers love you. So it's always a pleasure to have you with us. So welcome.
Well, thank you so much. I'm so happy to be here today, Rincy. Thank you.
Thank you. Many, many questions. So before we get into the crux of it, very briefly, tell us what is rare ovarian cancer and how many types of rare ovarian cancers are there that our overcomers should know about.
Yeah, thank you. Well, different organizations use different definitions. The NIH defines a rare cancer as one that affects less than 40,000 Americans. Now, when we talk about our different types of rare ovarian cancer, they actually oftentimes affect much smaller populations of patients, but we have many different types of rare ovarian cancer. So first, when we break it down, our most common overall type of ovarian cancer is epithelial ovarian cancer. So that's cancer arising from either the epithelial outer layer of the ovary, the fallopian tube, or the primary peritoneum. And that overall accounts for 90% of ovarian cancer cases. And then we have these much rarer subtypes of ovarian cancer that actually originate from the central portion of the ovary, like sex cord stromal tumors and germ cell tumors. So examples of those would be like granulosa cell tumor or dysgerminoma. So overall, within the scheme of those epithelial ovarian cancers, the most common type is high-grade serous ovarian cancer. And that accounts for the majority of our epithelial ovarian cancer cases, about 75 to 80% of them. And then we have these rare subtypes of epithelial ovarian cancer that can include low-grade serous ovarian cancer, mucinous ovarian cancer, endometrioid, clear cell, carcinosarcoma. So we really have these three distinct types of rare ovarian cancers: rare epithelial ovarian cancers, rare cancers originating from the inside of the ovary, like sex cord stromal tumors and germ cell tumors. Most commonly, when we're talking about rare ovarian cancers, we're talking about these rare epithelial ovarian cancers.
That's great clarification. Thank you. And so what percentage of ovarian cancers is low-grade serous? I think you just mentioned that. And how is it different from high-grade serous ovarian cancer? And there's a curious question. This is, straight from patient feedback is, could patients present with both low-grade and high-grade serous at the same time? Please share your guidance on this.
Yeah, so we actually used to grade serous ovarian cancer as grade 1, grade 2, and grade 3, similar to how endometrial cancer is graded. But we no longer do that. We now use a binary system of low-grade versus high-grade ovarian cancer because we now understand that low-grade serous ovarian cancer and high-grade serous ovarian cancer are really two distinct diseases and not a continuum for the vast majority of patients. Low-grade serous ovarian cancer accounts for less than 10% of epithelial ovarian cancer cases. Reports range between 5 and 10%. It's hard to know exactly. And generally, patients with low-grade serous ovarian cancer have a younger median age at the time of diagnosis. And really, we see two different groups of patients being diagnosed with low-grade serous ovarian cancer. Patients who are very young, in their 20s and 30s and early 40s, and then patients who are closer to the median age of diagnosis for high-grade serous ovarian cancer, patients who are in their 60s. Low-grade serous ovarian cancer does respond to chemotherapy, but has historically lower response rates to chemotherapy than high-grade serous ovarian cancer, and has a completely different molecular profile than high-grade serous ovarian cancer. Patients with high-grade serous ovarian cancer will almost always be found to have a p53 mutation in their tumor, while this mutation is not found in low-grade serous ovarian cancer. And that's one of our best tools for definitively differentiating the two types of tumors. There's other types of alterations that are more commonly found in low-grade serous ovarian cancer, most commonly those affecting the MAP kinase pathway, such as a KRAS mutation or a BRAF mutation. While high-grade serous ovarian cancer can be associated with a germline or somatic BRCA mutation in more than 20% of cases, the low-grade serous ovarian cancer cases are generally not associated with a BRCA mutation.
Okay, that's good to know. Thank you. So, as we are speaking about rare ovarian cancers, my next question comes to the granulosa cell tumors, right? We understand they are slower growing and, as you said, may not normally be very responsive to chemo as for rare ovarian cancer. So, what advances, if any, are in the horizon for this particular type of ovarian cancer that you would like to share with our overcomers? And are there any like upcoming clinical trials that you would like to mention that they could possibly look up and sign up for?
Yeah, thank you. So granulosa cell tumor, although it's a rare cancer with a very low incidence, so a very low number of new cases diagnosed each year, the prevalence is still quite significant because, as you mentioned, granulosa cell tumor is generally a more indolent, slower growing tumor. And so our patients live and struggle with this disease for many, many, many years. And so it's good that it's slower growing, but then at the same time, because of that, it's less responsive to chemotherapy, since chemotherapy generally works by killing rapidly dividing cells. And so unfortunately, our patients will have these slow growing tumors that can cause increasing symptoms over time. The mainstay of treatment for granulosa cell tumor is still surgery. So when someone has granulosa cell tumor, it's really important that a gynecologic surgeon remains part of your team, really for the duration of your treatment. Because a question should always be at the time of recurrence, is this something that we can surgically resect? Because doing surgery is really the best way for us to have a significant impact on the amount of tumor volume for our patients with granulosa cell tumor. Now, of course, surgery oftentimes eventually cannot become an option, so we do need much better systemic option for treatment of our patients with granulosa cell tumors. There's been a lot of interest in targeting hormonal therapies for treatment of this disease, as it commonly expresses the estrogen and the progesterone receptor, as well as the androgen receptor. There is an active study going on right now through the NRG for patients with recurrent granulosa cell tumor. It's called NRG GY033, and it combines 3 different hormonal treatments, one that targets the androgen receptor, as well as leuprolide and exemestane. So I think this is a very exciting study for patients with recurrent granulosa cell tumor. And I know that study is accruing very quickly across the country, but is open at multiple different sites throughout the United States right now. But it's important that we continue to look for ways to enhance the efficacy of hormonal or endocrine treatments for treatment of this disease, because we need treatments that are effective as well as treatments that are tolerable, as our patients will oftentimes be on treatment for a very long time.
So going back to your answer on surgery being the mainstay of treatment, so for patients whose cancer returns, right, for this particular subset, then how many surgeries on an average do you do on patients like these?
Yeah, it really depends. But over the course of a woman's life with granulosa cell tumor, they might have 3, 4, even 5 surgeries or more. Now, that's different than how we manage high-grade serous ovarian cancer. Most women with high-grade serous ovarian cancer will have their primary or interval debulking, and then oftentimes we will not do surgery again, or at most we'll do surgery a second time with a secondary debulking. Because granulosa cell tumor is less responsive to chemotherapy and more indolent, and patients oftentimes have this disease for a long time, patients will oftentimes have many surgeries over the course of their life, if appropriate. Of course, that decision is best made by a gynecologic surgeon.
Of course. Thank you. So, coming to small cell and clear cell ovarian cancers as well. So, what are the new advances in treatment for these subsets, and how? I'm just curious to know how are the treatment modalities different for BRCA versus non-BRCA mutation carriers when it comes to these types of subsets?
Yeah. So the vast majority of patients with small cell or clear cell ovarian cancer will not have a BRCA mutation. Most of the prevalence for our BRCA mutations are in those patients that have high-grade serous ovarian cancer. Now, that being said, all patients with ovarian cancer should undergo BRCA testing, and we recommend germline testing for all of our patients with ovarian cancer, and also somatic tumor testing as well, to look for any presence of a germline or somatic mutation. But generally, patients with clear cell or small cell ovarian cancer most commonly would not be found to have a BRCA mutation. For small cell ovarian cancer, there's really two different types of small cell. There's the type of small cell cancer that is similar to other types of small cell cancer in the body, the most common of which is lung cancer. So when a patient has a classic small cell cancer, we oftentimes treat it with modalities similar to how we would treat small cell lung cancer. But then there's another type of small cell cancer that can affect the ovary, which is the hypercalcemic type. And that just about 10 years ago was first described as being associated with a SMARCA4 mutation. And since that time, there's been a lot of work to try to better figure out how we could potentially target this alteration using immunotherapy or other modalities. And so that remains an active area of investigation. Clear cell ovarian cancer. So both clear cell ovarian cancer and endometrioid ovarian cancer, although they are grouped with the disease ovarian cancer, oftentimes arise in endometriosis as opposed to actually arising from the ovary, the fallopian tube, or the primary peritoneum. And so the genetic alterations that we see affecting clear cell ovarian cancer are actually closer to the molecular profile of endometrial cancer in many ways. The most common type of alteration we see in clear cell ovarian cancer is an ARID1A mutation, which is found in about 40% of patients with that disease. But then less commonly, we can also see PI3 kinase mutations, PTEN loss, and then sometimes we can also see KRAS mutations in clear cell ovarian cancer. So oftentimes our studies focused on patients with clear cell ovarian cancer right now might not be for the histology clear cell, but instead targeting those molecular markers, either through a study specifically for patients with gynecologic cancer or a basket study open to patients with all different types of solid tumors that have that same alteration. And so for patients with clear cell with recurrent disease, it's always good to know what type of alterations are found in the tumor and to be looking for studies that specifically target that alteration.
That's an interesting point that you made. And I'll just ask you in terms of symptom presentation, then, right? Because I think you mentioned that in certain cases, you could even use the treatment for lung cancer on these patients because of the nature of the small cell and clear cell, right? However, my question is when these patients present with symptoms and they are regarded as rare ovarian cancer patients, are they presenting the same symptoms like the other subsets of ovarian cancer, or are there distinct differences in that as well?
Yeah, it's so hard because there's no one good way to diagnose ovarian cancer. And as you know, this is something, unfortunately, that so many of our patients struggle with, that we don't have a good diagnostic test to diagnose ovarian cancer, and the symptoms can be really difficult to identify the ovarian cancer early on. So I'd say, for most of these subtypes, generally the presenting symptoms are oftentimes pelvic pain or abdominal bloating or GI
Similar.
symptoms similar to high-grade serous ovarian cancer. Sometimes patients with these rarer tumors like clear cell endometrioid or low-grade serous, sometimes they present with a larger mass at the time of initial presentation before there is diffuse dissemination of the cancer cells. So these patients with clear cell and endometrioid and mucinous in particular might be more likely to present with like a palpable pelvic mass or pain. But in general, they're all really hard to diagnose.
Okay, similar. Okay. So whether it be low-grade serous or other forms of rare ovarian cancers, is the percentage of recurrence different from the more common subtypes? In your experience, what have you seen? And what is the, you briefly mentioned immunotherapy. I'm going to go back to that. So what is the current and emerging role of immunotherapy in low-grade serous ovarian cancer and other rare cancers that we are discussing?
Yeah. So, some of these rare ovarian cancers are more likely to present at an early stage. Primarily clear cell endometrioid and mucinous might be more likely to present at stage 1 or 2, which is quite rare for high-grade serous ovarian cancer. So while overall the recurrence rates are similar, it can be a little hard to compare when the stage differential is different. But stage for stage, there might be a little higher rate of recurrence in these less chemosensitive types of cancer, like clear cell. But these tumors are also more likely to present at an earlier stage. So overall, we don't see a big difference in the numbers there. In terms of immunotherapy, so currently we don't have any immunotherapies FDA approved specifically for ovarian cancer. Now, of course, there are general approvals for indications like MMR deficiency or high tumor mutation burden in any solid tumor. But unfortunately, we don't see those biomarkers very often in ovarian cancer in general. Though I would say that the subtype of ovarian cancer that is most likely to be found to be MMR deficient is clear cell or endometrioid. So I do always make sure to check my patients with that type of cancer to see if they have MMR deficiency or high tumor mutation burden, because if so, then they would be an appropriate candidate for immunotherapy with a checkpoint inhibitor like pembrolizumab or dostarlimab in the recurrent setting. But overall, unfortunately, we've had several negative studies of immunotherapy in ovarian cancer in general, looking at both immunotherapy by itself in the Keynote study and looking at immunotherapy in combination with chemotherapy in studies like Javelin 100 and Javelin 200. And so it remains an active area of investigation, trying to find the right place for immunotherapy in ovarian cancer. But in general, if a patient does not have one of these markers like MMR deficiency or high tumor mutation burden, they generally should not be receiving immunotherapy for ovarian cancer outside of a clinical trial, unless it's a compendium listed indication.
Makes sense. Thank you. So you are doing some fantastic work and hopeful work for our overcomers. So tell us about all the groundbreaking advances that you are involved in, and that that could be truly scenario changing for our ovarian, like our rare ovarian community.
Yeah, thank you. So much of my research has focused on rare cancers, and in particular, I've always had a strong interest in low-grade serous ovarian cancer. And so our original work focused on deciphering the molecular profile of low-grade serous ovarian cancer and defining the incidence of MAP kinase alterations within that disease. This led to the development of studies with single-agent MEK inhibitors, which are now compendium listed for the for the treatment of patients with recurrent low-grade serous ovarian cancer. But most recently, we've been trying to build upon those response rates to find better ways to use targeted therapy to treat our patients with low-grade serous ovarian cancer. So the RAMP 201 study, which was performed through GOG and NGOD as an international phase 2 single-arm study, recently completed accrual. And the initial results of that study have been presented both at ESMO and IGCS. And in part A of that study showed that for patients with recurrent low-grade serous ovarian cancer, even in those patients that were heavily pretreated with 3 or more prior lines of therapy, the response rate to the combination of avutometinib, which is a dual MEK RAF clamp and defactinib, which is a FAK inhibitor, that this response rate was 45% overall for these patients with heavily pretreated low-grade serous ovarian cancer. And specifically in those patients that had a KRAS mutation, the response rate was 60%. So these are really high response rates to be seeing in our patients with recurrent low-grade serous ovarian cancer. And it was also really great to see that the overall rate of adverse events was pretty low. It was a pretty tolerable combination. And the tolerability was about the same for those patients that had less prior lines of therapy and more prior lines of therapy. So of course, we're really interested in further developing this combination of avutometinib and defactinib for patients with low-grade serous ovarian cancer. There is now a phase 3 study that's opening across the globe. It's now open in multiple sites in the United States, as well as Australia, opening now in Europe and also in Asia. And the study is called the RAMP 301 study, and it's for women with recurrent low-grade serous ovarian cancer who have had at least one prior line of chemotherapy.
Okay.
And patients that enrolled to the study are randomized to either treatment with the combination of avutometinib and defactinib, which are these pill therapies that have shown such good response rates in the recurrent setting, versus standard of care treatment with chemotherapy or endocrine therapy. And if you're enrolled to the standard of care arm, you decide together with your physician which one of those chemotherapies or endocrine therapies you receive. There's a whole panel of 5 different medicines you can choose from. And then obviously when you're going on a study, you want the combination, right? You want the new drugs. But so
I was just thinking that. Yeah.
But importantly, this study has crossover. So if you're randomized to the standard of care and it stops working or doesn't work for you, then you can cross over to the investigational arm and then receive the avutometinib and defactinib. So hopefully everybody who enrolls to that study would then be eventually able to receive these targeted drugs. We're also looking at this same combination earlier in the disease course now too, because people always ask me, you know, you're doing all this work to develop these treatments for recurrent disease, but I don't want recurrent disease. We need to bring these treatments to the front. We need to start these early to do everything we can to increase our cure rates, which is incredibly important. And you know, it is exactly what we should be doing. And so we've actually just opened a study at Sloan Kettering, where I work, for patients with newly diagnosed low-grade serous ovarian cancer who have advanced disease that's not appropriate for surgery, or who had surgery, but they still have residual disease present. And these are patients that have never received chemotherapy or other therapy for their disease. And patients who enroll to this study will be treated with this same combination of avutometinib and defactinib in combination with letrozole. And so we're hoping to now bring these promising results to our patients at their time of diagnosis as quickly as possible, so we can hopefully make an impactful change on people's life right now and not wait for the future.
That's very promising. So what you're saying is, if this particular study does well, then this could be an indication to the future where patients with low-grade serous, when they're newly diagnosed, they don't even have to go through the standard care, which is today endocrine and chemotherapy, even though we know that chemotherapy does not work so well for these types of cancers.
Exactly. Yeah, we want to bring the most effective treatments to the forefront of therapy. Exactly.
And so then it would be just pill-based from what I'm hearing.
Yes, these are all pills. Yep.
Okay. That is very substantially life-changing, in my opinion.
Yeah, and honestly, you know, we haven't done a head-to-head comparison, but I find the dosing of avutometinib and defactinib to generally be more tolerable than the dosing of a traditional MEK inhibitor, which is taken continuously, meaning that you take it every single day. With avutometinib, which is this dual MEK-RAF inhibitor, it's taken twice a week, 3 weeks on and then 1 week off. So you take the pill just twice a week for those 3 weeks, and then 1 week with no pills. And the defactinib is taken twice a day, 3 weeks on, 1 week off, but the defactinib has pretty limited side effects. And so because the dosing is intermittent and patients get this week off out of every month, I see that the side effects like the rash and edema oftentimes resolve and don't get as bad as they do when patients are being continually dosed, which is nice.
This is wonderful. And also the hair loss part of it, right?
Yeah, no hair loss. Keep your hair.
That's
No
significant.
neuropathy either, which is
Yeah,
nice.
that is excellent. No neuropathy, no hair loss, no chemo. You go straight to, after surgery, you go straight to pills and you just maintain your course of treatment. Wouldn't that be the day? Congratulations on this work. That's so hopeful. Thank you. So we talked about hope. Now let's talk about some challenges, right? I mean, we know that we have done so much, but we are still not there. So in terms of the biggest challenges we are yet to overcome, when it comes to rare ovarian cancers on a national and global scale. Uh, Tell us what your thoughts are, and then also in terms of patient knowledge and empowerment about this specific subtype of ovarian cancer. Where are the patients, and where do we need to bring them in terms of knowing what disease state or what kind of ovarian cancer they have?
Yeah. So I think on a national level, it's really important that these rare diseases be recognized. Our FDA still recognizes ovarian cancer as just one disease, even though we understand that these rare tumor types, like low-grade serous ovarian cancer, are a completely different disease than high-grade serous ovarian cancer, and we should be developing the drugs differently, not putting all those patients on one clinical trial. And so I think nationally, we really need to better understand how these diseases are different and treat them as separate diseases. And use things like the Orphan Drug Act to be able to accelerate development for these rare cancers, where we don't have as many opportunities for clinical trial enrollment as we do for more common cancers. I think on an individual patient level, it can be really challenging when you have a rare cancer, especially depending on what part of the country or world that you live in and what your access to healthcare is. I think it's okay to ask your doctor, have you treated my type of cancer before? Do you have experience treating this type of cancer? And your doctor should be truthful with you. And if they haven't treated your type of cancer before, it can be really helpful to get a second opinion and to make sure that you're on the right track and that you've had the right type of testing done on your tumor. The treatment of ovarian cancer has dramatically changed over the past decade, and we have many more targeted therapies and many more molecular tests that we do on ovarian cancer than we did just a few years ago. So you don't want to miss out on any of these opportunities by not having the right testing done on your tumor. It's always okay to go for a second opinion, and as a physician, I never mind if my patients get a second opinion. It's, send me their note. Let me know what they said. If they have a study that's better for you, I want you to be on that study. We're all on the same team here. So it's always okay to advocate for yourself, and you should. And that might involve having to visit multiple doctors over the course of your treatment.
Thank you. So you raised a good point on how we empower our overcomers in asking the right questions, right? It's a great segue to my next question, which was, what questions should our overcomers be asking of their healthcare team when diagnosed with ovarian cancer, especially if they're told that it's a rare subtype? But just from our experience, it seems like these kinds of conversations don't routinely happen. Like patients in certain situations in community settings, etc., they're not even oftentimes, it's not shared with them that you have this type of ovarian cancer. All they know is that I have ovarian cancer. So talk to us about this. How can we break this barrier, and how should the patients be empowered?
Yeah, that's a great point. That oftentimes people do just hear that they have ovarian cancer, and they don't know what type it is. And like we've been talking about, it makes a really big difference what type of cancer it is. And so I would recommend that question you just posed there and see, like, people should ask their doctor, what type of ovarian cancer do I have? Is this a rare type or a common type? And what are the molecular profiles that you're looking for in my type of cancer? And so particularly if the cancer recurs and you have a rare cancer, there's specific markers you should be looking for. For patients that have newly diagnosed cancer, the main thing that we're looking for is whether someone has a BRCA mutation or HRD, and that applies more to high-grade serous ovarian cancer. But the most important thing that could potentially be missed, in my opinion, is testing for these specific targetable alterations. So I would definitely recommend, as you said, that people specifically ask their doctor what type of ovarian cancer they have and make sure that their doctor knows, because that's very important. But then when asking about specific molecular testing, there's really 3 different groups of testing that should happen on ovarian cancer samples. Specifically, by the time, if the cancer is recurrent, then all 3 of these types of testing should have happened. So one of them is germline testing. So that's doing testing on your normal tissue, like your blood or your saliva or your fingernails, to see, are there any hereditary mutations that you have? These are usually ones that you could have inherited or that you have the potential to pass down to children potentially. And of course, the one we're most commonly looking for is a BRCA mutation, but people can have other hereditary causes of cancer as well. So everybody, especially by the time they've completed their initial treatment for ovarian cancer, should have germline testing done. And that's everybody with every type of ovarian cancer. And then also patients with newly diagnosed disease who have advanced stage disease, if they do not have a BRCA mutation, should have HRD testing done if they have high-grade serous ovarian cancer. Can also be considered for patients without high-grade serous, but if you have high-grade serous, you should definitely have HRD testing done if you do not have a BRCA mutation. If you do have a BRCA mutation, by definition, your tumor is HRD positive. The second type of testing is somatic tumor testing. So that's testing looking at specifically what mutations happened in your cancer cell. So these are not inherited mutations. These are mutations that happen specifically inside of your body and your cancer cells. And so that can be different types of alterations, like a BRCA alteration, but also alterations like a KRAS mutation, a BRAF mutation, PIK3CA mutation. And this can be important both for standard of care therapies and for clinical trials. So of course we want to know if you have a molecular marker for a clinical trial, but this also affects standard of care therapies. Obviously we have treatments for BRCA mutation like PARP inhibitors. We also have treatments for things like a BRAF mutation that are FDA approved combination pill therapies. And so it's really important to know if you have these alterations. So those are both sequencing, germline testing, and somatic tumor testing. The third category is immunohistochemistry. So this is IHC testing done on slides from your tumor tissue. And so there's multiple different IHC markers that we now look for in ovarian cancer. These include folate receptor alpha, which is a target for drugs like mirvetuximab. Also HER2 amplification, which is a target for drugs like Enhertu. And then also MMR deficiency, which is also an IHC test. So it's really important to have both the germline testing, the somatic testing, and then these IHC tests to look for these potential targeted therapies. And I would say that that's something that patients come to me sometimes that they haven't had done yet, and which you just don't want to miss out on some of these really promising drugs.
And as you were talking about this, I was exactly thinking that I do not think all these testings are happening in community setting hospitals. I really would doubt that. I mean, if it's happening, it's great, but all the 3 levels of testing that you're talking about at MSK, I mean, I believe that 200%, but I'm not sure whether this is actually happening. Our overcomers will tell us, but I would be doubtful. So thank you for mentioning, because now, we have the knowledge, and our overcomers then can go question their physicians and healthcare teams that, have you done all these testings on me? So thank you.
Yeah, and everybody has the right to have these testings done.
Exactly.
It's covered by your insurance. It's reimbursable. So it doesn't require a special level of care. These are things that as a patient, you have a right to have done on your tumor tissue.
That's exactly my point. Thank you so much. So you very briefly mentioned this. I'm going to come back to this rare subtype, which is the ovarian carcinosarcoma, right? How is it different from the endometrial counterpart of the carcinosarcoma? And tell us a little more about these subtypes, and how has the science progressed in answering the unanswered questions on these particular subtypes of rare ovarian cancers?
Yeah, so that name carcinosarcoma refers to what this tumor type looks like under the microscope. So when we look at carcinosarcoma tumors, they appear to have a mixed histology where part of it looks like carcinoma, so that would be like regular in the case of ovarian cancer, epithelial ovarian cancer, and then part of it looks more like sarcoma, like a tumor developing from a muscle layer of a cell. So, about 15 years ago, we used to think that these carcinosarcomas were actual sarcomas and used to use sarcoma treatments for this disease. But we now understand that the progenitor cell, the cell that these cancers first start from, is really an epithelial cell. And so now we treat carcinosarcoma of the ovary the same way generally that we would treat epithelial ovarian cancer. When carcinosarcomas recur, it's usually the carcinomatous component that is the main driver of that recurrence. So in the case of ovarian cancer, the carcinomatous component of the carcinosarcoma most commonly is similar to high-grade serous ovarian cancer. And so we look for those same markers that we look for in high-grade serous, like BRCA mutation, HER2 amplification, but generally would treat towards that carcinomatous component. Similar story for carcinosarcoma of the uterus, that we would treat that similar to how we treat endometrial cancer, as opposed to how we treat endometrial sarcoma. So we really treat it more like the endometrial cancer. And then that carcinomatous component of the carcinosarcoma can be either endometrioid or serous, most commonly. And so when the carcinomatous component is serous, then we look for those same markers that we would see in serous endometrial cancer. If it's endometrioid, we look for the markers we would look for in endometrial cancer. So in the case of endometrioid, like ER/PR positivity, in the case of serous, HER2 amplification. So we really treat it towards those individual components, and generally, in most cases, do not treat it like a typical sarcoma.
Okay, thank you. And I'm assuming that they also present similarly with the other ovarian cancers with the similar symptoms. And in terms of the progression of the disease, do they follow a similar trajectory? Or because I think you mentioned that the rare subtypes have a higher recurrence rate. So do you see that for these subtypes as well, or?
Well, the ovarian carcinosarcoma, yes, it can be more likely to recur. Similar to other types of ovarian cancer, it can disseminate quickly at time of recurrence. But we treat it generally with the same types of chemotherapy that we would use for other epithelial ovarian cancers.
So just generally follows the same pattern and path that others do. Okay. So, in terms of the system, right, the healthcare system, it's some of it is good, some of it is not. So as a healthcare professional, what are the system flaws that rise to you when it comes to management of ovarian cancer, and what can we do better for our overcomers, you think?
Yeah, I think it is true that there are definite disparities in healthcare, and that unfortunately, not every patient in the country gets the same level of care, which is unfortunate, right? Everybody should get the same level of care and have access to the same treatments. And it can be hard to fix those systemic issues. And I think it's really important that people like you are working to empower patients so that at least we can all have patients on the same equal footing, who can advocate for themselves. I wish patients didn't have to advocate for themselves. That would be easier and better. But it's something that we can do to try to help even the playing field so that everybody's getting access to the same level of care. I think really important things are to not be afraid to advocate for yourself. I think it's good to bring a friend or family member with you to appointments so you have a second set of ears listening. And also, if there's questions you forgot to ask, they can make sure to ask them for you. I think it's great to review with your person that comes with you to your appointments ahead of time what your key questions are so that you together can make sure that you get those across. unfortunately, doctor's appointments are scheduled as like these 15-minute slots that are, really short. And so your FaceTime with your doctor might be relatively short. So it's really good to write down all of your questions ahead of time so that you can make sure that you get through all of them. Don't be afraid to ask questions. It's good to ask questions. We love it when people ask questions. And so never be afraid to do that or to advocate for yourself. And sometimes it's okay to ask the same questions multiple times because sometimes the answer changes over time, so it's okay. It's okay to keep asking it. But and I wish people didn't have to advocate for themselves in that way, but I do think it makes a difference. And so everything we can do to encourage our patients to have the best supports possible, so that they can make sure that they're getting the best health care possible.
Thank you. And so, what do you love most about your job, Dr. Grisham, and what has been the biggest learning lesson in caring for our overcomers with rare ovarian cancer? What has been your biggest takeaway?
Yeah, well, I love giving good news, of course. I mean, I feel like that would be everybody's answer because it's, we get to give people, of course, we have the privilege of taking care of patients through their entire disease course, and a lot of things are not cheerful, and we struggling with side effects of treatment and end of life care. But sometimes we get to give people really good news, and sometimes we have complete responses, and sometimes we have surprisingly good responses. And I love celebrating with my patients when we've had a really good response to treatment or a really long remission, or it's always especially exciting if they're having a great response on a clinical trial. And so, it's such a privilege to be able to participate in my patients' care and to work with them to try to get the best outcomes possible. And we're really working together to try to make these advancements over time. And then, I'd say, so I've been here at Sloan Kettering for 15 years now. And, I would say that I'm still constantly being surprised. There's always patients that surprise me. You might think you know what's going to happen in somebody's disease course, but I always say to my patients, I've seen every possible scenario happen. So, it's our job to tell people, based on statistics and clinical trials, what the most likely scenario is. But there's always surprises. There's people that have incurable cancers that somehow seem to be cured, and there's people who have these really sustained responses to treatments when we're not expecting it. And so you never quite know what you're going to get. And plus, treatments change, and they change during the course of our lifetime. Things are always changing. And so, I think we need to always be working towards that progress, and it is attainable. And luckily, we still keep getting surprised by people having surprisingly good outcomes, which is great.
Which is great, but I also think it's also because of the hard work that you and other doctors and physicians and scientists are putting out there, because you are making miracles happen every day. So we thank you for the great work that you do, and we know how relentless you are in trying to find the best solution for our overcomers. So your message of awareness to younger women who frequently get diagnosed with low-grade serous ovarian cancer. I understand that they are maybe at different stages in their lives, and if their challenges are somewhat different than a woman who gets diagnosed, in her 50s or even 60s, right, or beyond. So how should younger women advocate and overcome the challenges they generally face in receiving timely treatment due to repeated oversights? And the reason why I mentioned this is we have had, and I'm sure you know this too, there are so many overcomers, younger overcomers, that tell us that we kept going to the doctor, we kept reporting our symptoms, but they just would not believe that a person of my age would get cancer, and that just put it down to something else, or sometimes even mental health issues, which is distressing, right? So tell us, what is your message that you would want our younger overcomers with low-grade serous to take away?
I know it's such a challenge because these rare cancers are rare, right? So most young women do not develop cancer, and so it's not usually the first thing that somebody's primary care doctor is thinking about. And it's my patients already have cancer when they come to me. So it's easy for me to say, oh, you had these symptoms, but it might have not been so obvious at the time before the diagnosis was made. And so it can be incredibly challenging, especially for a disease like this, where we have no good screening tests,
Yes.
and where the symptoms, can overlap with other things like irritable bowel and things like that. And so, I think when it's incredibly hard. And again, it's so hard that we put so much emphasis on the patient having to advocate for themselves. But I think that the main thing is that if you feel like you're running into a wall with your physician, and you don't feel like they're hearing what you're saying, or that they're not adequately addressing your concerns, it's totally okay to go to another doctor. And oftentimes, unfortunately, I think that's what usually happens. The patients were going to one doctor, they kept telling them everything was fine, and then eventually they see either a GI doctor or some other type of doctor that then finds the cancer. And so I think this is another time when it's good to get a second opinion if you don't feel like you're being heard, or you don't feel like you've had an adequate response to your concerns. And that's always okay to do. And but it's and luckily, sometimes it turns out that everything was fine, which is good. And then that's just some lost time and effort, and that's okay.
That's
But if you feel like something is wrong, I agree, you should persevere. And oftentimes, yeah, if you keep going to the same doctor and they're telling you the same thing, I think it's best to just change and go to a different doctor.
And I would like add to that is when eventually they do get diagnosed and come to a physician such as you, having conversations about future family planning, or fertility issues and body image issues. These kinds of things are not trivial. I mean, especially for women of childbearing age. I've also had overcomers tell me that, which it should not really happen, is that they had surgery and they woke up to the news that they couldn't be, mothers ever in their lives again, or ever. Those are life-changing moments, and then there should be a discussion with the patient and the physician and the family members before they are taken under the surgery or taken to the operating room. It's from direct feedback that I'm sharing this with you, which I think is not right. So
Yeah, no, I totally agree. Women should actually always be consented prior to loss of fertility. And so, sometimes when we go into and I'm not a surgeon, I'm a medical oncologist, but sometimes when our surgeons go into surgery, they don't know ahead of time what the extent of disease is going to be, or if there's going to be cancer there. But it should always be discussed with the patient if there's a chance that they might have loss of their ovaries, or their uterus, or if the patient expressed before surgery that they did not want to do that at this time, or they wanted to make a more informed decision, then oftentimes this can be done as a multi-part surgery, such as like going in first with a laparoscopic surgery to see if there's evidence of cancer, being able to tell and take biopsies of what exactly is going on there, and then closing, and then having a complete discussion, and then deciding if you should go back in for a completion surgery. So we oftentimes use this staged approach in our younger patients so that we're making a fully informed decision before doing that irreversible surgery. And so really a woman should know beforehand if there's a chance of them having removal of their ovaries or uterus. And if they're not aware of that, or if it's uncertain and they don't want to proceed with that surgery at this time, a staged surgery is always something that could be considered.
yeah, and when we are talking about patient empowerment, this is sometimes the biggest decision that a woman
Yeah.
is ever going to make in her life, right? So very important. So
Oh,
about
Lindsay, I just want to mention too, also just going back to that discussion, of course, it's always nice to have a discussion with REI before a surgery like that also. Sometimes we feel very rushed to make these decisions when you have a new diagnosis. But if you're of childbearing age, you can also discuss with your doctor if you're appropriate to have egg harvesting prior to surgery, for potential future use for IVF or for surrogacy. So sometimes we feel like rushed to skip that step when it's a new diagnosis, but always something you can bring up with your surgeon to discuss if that's an option prior to surgery.
That's a very important point. Thank you. So this has been a great discussion. Lots of questions you've answered. What would you like to mention that I haven't asked you yet?
Well, I would just like to say thank you to you and your group and all the wonderful work you're doing to empower women, inform women, and to really help drive better treatments for ovarian cancer and better support for the ovarian cancer community. So without people like you, we wouldn't be making nearly as much progress. So thank you so much.
Thank you. And my last question that and you have answered this before for us, but what message of overcoming would you like to share with our overcomers that are listening today?
Yeah, I would just say that, progress is being made, changes are happening every day. We're constantly surprised by how well our patients are doing, which is good. And so, and the future can always change. Even if things are in a stressful period right now, we don't know what tomorrow is going to bring. And so I think it's best for us to just focus on all working together to have the best treatment options possible, and hopefully we'll continue to make progress every single day.
Thank you, Dr. Grisham. This was a really insightful discussion. We went in depth about all kinds and all types of rare ovarian cancers, and you are involved in such brilliant work for low-grade serous. So we are very thankful to you and to your team and everyone that's involved in this space for making lives better for our overcomers. And thank you for your time today. And overcomers, as I always say, I know that this was a great episode because we have talked about so much about rare ovarian cancers. If you have any questions, please reach back out to us and we'll try to get it addressed by Dr. Grisham post the discussion. And you keep watching, and we'll be back with the next episode of Connect Over Coffee very soon. Until then, you keep inspiring and keep overcoming. Thank you and bye.